Hello, and a very warm welcome from all of us at MedExam Expert today to this free webinar that we've arranged for all of you. A very warm welcome. Thank you so much for being here with all of us. We are very grateful that you're all here. I hope you're all doing well. Is my voice audible and clear now? Deepak, Mariam, are you able to hear me now?
Yeah. Good evening, ma'am.
Good evening. I hope you're all doing well.
Yeah, trying.
Okay, perfect. That's great. All right. Well, welcome to all of you. We are really happy to have you all on board with us. A very warm welcome to all our co-students who are here as well. All right. Before I begin or before I jump on to our agenda, I just want to say that that's great, Nasreen. Thank you. All right. I just want to say that today is your opportunity to build the tomorrow that you want. The tomorrow that all of us want is to be able to crack MRCOG Part 2, be able to crack MRCOG Part 3, and get the prestigious degree that MRCOG is, and be able to stand at the convocation and receive that award. Trust me, it is a very beautiful feeling, and I'm sure you're all here. You've cleared your Part 1 MRCOG. Congratulations to all of you who are here and who cleared their exam. I'm sure in a couple of months, sooner than later, we'll all be meeting again. We'll all be celebrating your passing of Part 2 MRCOG as well, with a little bit of effort from our side, with a little bit of effort from your side. I'm sure together all of us can do it. All right. So is there any questions that anybody has that if you want me to cover it, if you want to tell me right now so I can cover them, or if not, I'll start with the session. I'll cover all the MRCOG Part 2 exam essentials that you are all supposed to know. And if you have any doubts, meanwhile, just save them for later. And before we start the VTE guideline, I'll take all the questions then. Okay, I hope that makes sense. If you have any questions, you can ask me right now, or we'll take them after I touch upon the exam essentials. Okay, anybody has any questions?
No, ma'am, please start.
Okay, thank you. All right. So before we begin, let me tell you all about the exam format. So this is going to be a computer-based test. Initially, a couple of years back, it used to be a paper and pen-based test, but now it is a computer-based test. It happens in the Pearson VUE Center. There are two papers. There's a paper 1 and there's paper 2. Now, both these papers have equal percentage of marks. Both the papers have 50% marks. There is no specific distinction as such. In the sense, it's not like paper 1 has obstetrics and paper 2 has gynac. But yes, more of obstetric questions are covered in paper 1 and more of them in paper 2. But the college doesn't give you an exact line or an exact demarcation in the sense what paper 1 has and what paper 2 has. But they both carry equal weightage. They both have 50% marks. All right. So now both these papers will have single best answer questions and extended match questions. Okay. I'm sure that all of you here are at different stages in your preparation. Some people might have, already given the exam, or some people might have just started who are absolutely clueless. So we will be taking this session as if we are starting from scratch and we don't know anything about the exam, and we'll take it forward from there. Okay. So we have in the exam, we have single best answer questions and we have extended match questions. Unlike the Part 1 MRCOG exam, where there were only single best answer questions, the difficult part in MRCOG Part 2 is the presence of extended match questions. And I'm sure if you've all studied and if you've all done extended match questions, they are slightly more complicated than the single best answer questions, all because there are so many options. There could be 10 to 15 options and they're all pretty close to each other. So it's very easy to make a mistake in those unless and until your guidelines are crisp and clear and on your fingertips. Okay. Now, in terms of the marking distribution of single best answer questions and extended match questions. So 40% of the marks, of the total marks in each paper, is given to the single best answer questions, and 60% of the marks is given to extended match questions. All right. So what even the college recommends is that you should be giving 40% of the entire time that you have to single best answer questions and 60% of the time that you have to extended match questions. Now because I'm talking about time, so each paper is of 3 hours or 180 minutes each. And there is no specific time limit as such in terms of the questions. You can take 3 hours and solve all the questions in that particular paper in 180 minutes. You will have a break after that, and then you'll begin your paper 2. That would again be of 180 minutes or 3 hours. Now, a lot of students ask that what is the usual pass percentage? And a lot of people even reply saying, it's usually 62%, it's usually 64%. So now in terms of the passing criteria, it is a standard setting in the sense the passing criteria depends upon the difficulty of the question paper. It depends upon how the students have answered the questions and how easily they have answered a couple of questions and how how much difficulty they had solving the difficult questions. And it cannot be decided before the exam. It's always decided after the exam, and you would be studying in your part 2 in the teaching module that this is called the criterion reference. All right. I hope I'm making sense till now. I hope I'm being clear up till now. If I'm not clear at any point, please do not hesitate to stop me and I will happily repeat it for you.
Proceed, ma'am.
Okay, thank you. All right. So this is about the exam pattern. Okay. So a couple of things about single best answer questions. So you will have 5 options for a question. There would be 5 answers, which would most likely be arranged either in a numerical manner or in an alphabetical manner. And it is wise to always pick an answer. It is wise to always choose an answer for the single best answer question, because there is no negative marking. If you choose a wrong answer, you will not lose anything. Okay. A lot of times in single best answer questions, you will have an answer which wouldn't be the exact answer to the question. In that situation, what you have to do is pick the answer which is closest to the question or the answer that they are expecting. Okay. Sometimes you'll be like, okay, none of the options match or nothing fits. In that situation, please choose something that is closest to whatever they are expecting as an answer. Okay. Now coming to extended match questions. So extended match questions are going to require a lot more practice as compared to single best answer questions. The one most important thing in terms of solving EMQs is having your algorithms on point or having your algorithms on tip. In the sense, by algorithms, I mean for management of each condition, you need to know what is the next step. You need to know that a patient has come to you with, say, heavy menstrual bleeding. You need to know when to examine the patient. You need to know when to send investigations. You need to know what investigation should be sent. When the patient comes with a diagnosis, for example, if the patient comes back with a diagnosis of endometrial hyperplasia, you need to know what to offer the patient. You need to know when to refer the patient to an oncosurgeon. You need to know what investigations you need to do before referring the patient to oncosurgeon. I hope I'm making myself clear. In the sense, the algorithm or the management guideline of a particular topic needs to be crisp and very clear. You need to be very, very thorough about what should be the next step in management. That is what they will be testing in your extended match questions. And we'll be doing a lot more of these in our sessions on our groups as well. So as we keep solving, it'll keep getting easier and easier. Now, just to give you an example of an extended match question, there would be a heading in which they will be asking you, which is the first step in management, and then there would be 10 to 14 options, okay? And then there will be a question. Now, when I said which would be the first step in management, now this first step in management is your lead-in statement, the lead-in statement that I've mentioned right here. All right. This lead-in statement that I've mentioned, it would be which would be your first step in the management. Okay, you have to be very thorough. You have to be very careful when you're reading this particular sentence, because I'm sorry, because if you mistake the first step to be which is the most important step, or for example, which is the first investigation that you will be doing for example, for management of molar pregnancy, in management of molar pregnancy, which is the first investigation that you'll be doing, and which is the most important investigation, or which is the gold standard, right? This is how the wordings change, and that is how the lead-in statement would decide the answer for you. So it is absolutely important you read that first sentence very carefully, okay? And the next step to do is not read the options. So there are 10 to 14 options. Please do not read those. You read the question, the first question that is given, okay? Read the question, have an answer in your mind. Once you read the question, you'll know, oh, this is what they must be expecting. And then you start reading the options. And in the options, if you find what you were thinking about, that is most likely going to be your answer. Because if you go the other way, if you read the first statement, if you read the 14 options, and then you read the question, most likely the possibility is that you are going to forget all the 10 to 14 options that you have read, and you're going to read it all over again. How this is going to harm you is, one, you're going to get confused. Two, you're going to lose precious time. Okay, time is always a crunch in these exams, and you have to be very careful to utilize your time well. Okay, I hope I'm making sense when I'm saying how to solve extended match questions. Again, even in extended match questions, there is no negative marking, so it is advisable to attempt all the questions. Now, one important thing that I found very interesting or very helpful in the computer-based test was flagging. So there is an option to either choose the answer or to attempt to answer that question later, or flag that question. So it's a very important tool when you're unsure of what you've chosen, or when you're unsure and you are short of time and you do not want to get involved in a question which you're not confident about, please flag that question and move on. So when you're reading it for the second time, when you're maybe at peace because you've solved a couple of questions or you've done the entire paper, and now you're ready to see the questions that were a little confusing or that were a little complicated, you would be at a better place to solve that particular question. Giving you an example of my exam, I think I had flagged almost 10 to 15 questions. And when I went back and saw, I had done so many silly mistakes and such small mistakes. If I wouldn't have flagged them, and if I wouldn't have gone and reread those questions, maybe I wouldn't have cleared that exam, and maybe I would have required another attempt. So please do utilize it as in when you feel the need to. Okay, I hope the part about SBAs and EMQs is clear. If anybody has any doubt about the type of questions that come, please do let me know before I move on to the next part of the presentation. I hope no doubts, or I hope I'm hoping that you're all here with me and you're all listening to what I'm saying. Are there no doubts? Is it absolutely clear, or are you not listening at all?
Yes, ma'am, it's all clear.
It's clear. That's great. That's great. Thank you, Aisha. Yeah. All right. Okay, let's move on then. Okay. So now we've understood what the exam is going to be like, right? Now we need to prepare for the exam, and what exam study material do we have? So I've had lots of students asking me, do we need to read some books? Do we need to like read Dewhards, or do we need to read Williams, etc.? A very straightforward answer to that is no, you do not need to read any books. All the questions are going to come from the guidelines from the college. You do not need to read any books to be able to answer all these questions. Okay. Now, in terms of importance, coming from top to bottom, the most important study material that you have is the Green Top Guideline, or the GTG. Now, they are the highest in level in terms of whenever there is a confusion between a Green Top Guideline and some other guideline. For example, if there's a confusion between a Green Top Guideline or NICE Guideline, or if there's conflicting things given in a Green Top Guideline and a TOG article, you would always choose what is given in the Green Top Guideline, except for sometimes where there could be a little discrepancy. For example, the sepsis TOG and the sepsis Green Top Guideline, right? The sepsis Green Top Guideline is quite old. It is a 2012 guideline, and the TOG article is fairly recent. So a couple of things which is given in the TOG article are given preference over the GTG, but this is a rare exception. As a rule of thumb, the Green Top Guideline is supposed to be given the most important, or it is the most important guideline that you would be reading for your preparation for MRCOG Part 2. Okay. As in when there are any exceptions, we would be covering them in our session. But for now, you make it a point that GTGs need to be done first for sure. And any discrepancy, whatever GTG says, needs to be given preference. All right. Now, the next thing is the NICE guidelines. So NICE guidelines, unlike Green Top guidelines, it can be a little vague, right? It is very difficult sometimes to make a point of what the NICE guideline is saying. It is very difficult to convert these NICE guidelines into algorithms. And that is where we come into picture. In the sense, we make them into algorithms, or we try to make it easier so you can grasp it, or we try to make it a little palatable for you. Okay. NICE guidelines, again, are very important, especially like intrapartum NICE guidelines, especially infertility or subfertility, for which there are no other guidelines, so there are no Green Top guidelines as such. So these NICE guidelines have to be very thorough. So all the Green Top guidelines, all the NICE articles are very important. There is nothing in these two that you can miss. Okay, these have to be thorough. Now coming to TOG articles. TOG articles are the new favorite. Now everybody's doing TOG articles, but everybody's confused if TOG articles are actually important. Everybody's confused about how to make sense out of it. And the most important thing, how many TOG articles are to be done, because there are so many of them. Right? So regarding TOG articles, what I would like to say is, one, the TOG articles for which there are no Green Top guidelines, no NICE guidelines. For example, there are tons of TOG articles in the Urogynecology, lots of TOG articles in subfertility. Now, these are really important and these need to be done. Okay, there are no excuses not to do them. But there are quite a lot of TOG articles that are not necessarily important. Okay, we've made a list of all the topmost TOG articles, the second most important TOG articles, and the TOG articles which you can, easily ignore and not do. We would be providing that to you during the course. All right. And in terms of TOG, what is the most important thing when you're studying is to be very thorough with all the tables and all the flow charts. Okay. They will very rarely ask you incidences from them. Okay. They will very rarely ask you an SBA asking, how much was the recurrence or how much was the incidence of this particular condition. But yes, they will ask you algorithms in EMQs. yes, they will ask you those tables that are there and which are extremely, extremely important, right? Like for urogynecology, the uroflowmetry and the talk article for that, all that is extremely important and you have to be very thorough with it. Now, other articles that we have are the scientific impact papers, the FSRH guideline or the BASH guideline, the MBRACE report, consent advice, clinical governance, and teaching. Now, all these are quite lengthy for you to read now if you're thinking of taking the Jan exam, or for that matter, if you're appearing for the September exam. These things can very easily be done from the summaries that are there on your portal. I'll be showing you in some time about what our website looks like and how the summaries are provided to you. But you do not need to go into the details of SIPs. All the FSRH guideline and the BASH guideline, which would be covered in the sexual and reproductive health module. Only the recommendations from these guidelines is enough. You do not need to go into the detail and try to read each and every page because they are really, really, really long guidelines. Okay. Also, the MBRACE, very few important things would be needed for your exam, and we'll be telling them to you in due course of time. Okay. So now we know that this is the study material. Okay. All this study material is freely available on the RCOG website. Everything is available except for a couple of talk articles which are paid, but rest everything is available. For students who are on the course, for people who are not on the course, you can always tag me on the guide group or anywhere if you need any article, and either me or somebody from the backend team will definitely be able to provide you with whatever study material that you require. All right. So now that we know what the guidelines are, let us talk about how to utilize these guidelines, right? Or how to go about them when you're studying for your Part 2 MRCOG. Okay. Now, the first thing to do is to read the guidelines, that is the Green Top guideline, the NICE guidelines. Very important when you're reading for the first time to make notes. Okay. I would always advise anybody who's studying, especially now, if you're aiming for your January exam, it is highly recommended that you make notes out of whatever you're studying. Especially, for example, when you're studying a NICE guideline, if you can frame that one particular sentence in your own words and write it, or if you can make flowcharts out of whatever they are saying, it would be very, very easy for you to remember it. It would be very, very easy for you to reproduce it. But more important than that, it would be very important or very easy for you to revise it. Okay. So always make notes. In some time, I'll be telling you how to make notes when we'll be covering the venous thromboembolism guideline. Okay. So very important to make notes. I agree that everyone is busy. Everyone has, I'm sorry. Everyone has work, everyone has a family, everyone has chores and so many things. But the first time that you're reading, put in your 100% effort. It might take a little extra time. Give it that much time. But make sure that you make your notes, because the next time that you're revising, you would be saving 50% of that time by not going through that entire guideline and trying to figure out what the guideline is saying. But you will be reading your own words in your own handwriting. And how notes are going to be beneficial is that you would be adding points from the questions that you're solving. So now, as you keep reading your guidelines, side by side, for example, if you are giving 6 hours a day to study, if you are studying for 3 hours or you're reading guidelines for 3 hours, please keep 3 hours for solving questions. If you don't want to do that, if you want to keep 4 hours for studying at the initial stages, please keep 2 hours for solving questions. Now, how you want to solve these questions is just go cover by cover. It is very difficult to, pick up one topic and then scan the entire book and select that question and solve it. So just keep going cover by cover, and as and when you keep coming across that particular question, you will be able to remember it, or you will be able to register it. Okay. So now whenever you're solving these questions, whenever you find something new or something different which you've not found in your guideline, go back to your notes and add this point there. Okay. Also, for example, whenever you're reading your heavy menstrual bleeding nice guideline, or whenever you're reading, nice guideline of subfertility, and you come across a relevant talk article, instead of just having scattered notes everywhere, put all the subfertility together. So you read the nice guideline, then you read all the relevant talk articles and add the notes in the same place. So when you're revising for your exam, you revise the entire subfertility in one go. You have all the relevant things at one place. What I would do is I would make folders and I would keep adding pages to it. That was very easy because in notebooks, you have a tendency to keep writing one page after the other. So I would write on sheets and I would keep adding papers to the folders or to the files that I had made. So that is one good way to, keep everything which is relevant or which is related to each other in one concise or compiled place. And as you keep solving questions, as you keep reading more, you will have more and more information and your notes will keep growing, right? And for example, if you're appearing for the January exam, imagine you are in December and you just have your notes, which you've already gone through so many times. You just have your notes to revise and you'll be able to finish one module in one day. Something that will take you 10 days now, or something that will take you 10 to 15 days maybe now, will take you hardly a day just before your exam. Okay. I hope you're all with me, and whatever I'm saying is, resonating with all of you.
Yes.
Yeah.
Yes.
Okay, that's great. All right. So, and the most important thing, which I'm sure you've all given so many exams and you've all cleared so many exams, but I think more so for Part 2 MRCOG because it's such a theoretical exam and there are so many numbers and so many incidences and so many flow charts and algorithms. Very, very important to revise the entire thing at least 3 to 4 times before you go for the exam. It is mandatory because green top guidelines, the recommendations have to be on the tip of your tongue. The nice guidelines, certain incidences, not all of them, but certain incidences have to be on the tip of your tongue. There is no way you can get them wrong because the 90% others will get them right. Okay. Are the summaries given in course enough, or do we need to make our own notes too? Well, Dr. Anand, that's a very good question. Okay. Personally, I believe read the guideline, read the original article, try to interpret it in your own way, try to make your own notes. Okay. So in the course, you would be given a schedule for an entire module. And towards the end of the schedule, we will be taking a class for you, summarizing the entire module. Now, sometimes the modules might be bigger, like maternal medicine. So we will split that module into 3 or 4, and you will have respective mini schedule for that particular class, right? What I would suggest is go through the original article yourself, make your own notes, and if you feel that you're not able to do it on your own, if you feel that you do not have any time, then yes, you can definitely go through the summaries which are provided for you on your portal. But I never feel satisfied whenever I read these summaries. These summaries are provided to you for your own help when you're short of time during exams, in case you've not made your notes, or just to be, whenever you're on the go and you have your phone and you just want to revise and you don't have your notes for times like that. Okay. But personally, when you're studying, please read the guideline, make your own notes. It is very beautiful, when you pass the exam and you look back at those notes, you look at them with a feeling of so much of pride, and it's your hard work, and your hard work you will never forget. So yes, it is all for you. The summaries are for you to use it the way you want. But personally, please, I would say read the original article. It will teach you a lot. Okay. I hope I answered your question, dear Anam. But when it comes to a certain talk articles, when it comes to BASH guidelines, FSRH guidelines, SIPs and stuff like that, yes, you are free to go ahead and just do the summaries. That would do. Okay, that's great, dear. All right. So I hope I made the point about how to go about the material and how to go about studying when you are when you start studying for your sessions and for your exams. Okay. Now, a couple of things. I think I've already told you that. Okay, somebody has a question. When reading GTG, is it enough to just read the exam? No. Yes. All right. So, Humaira, I was going to touch upon this in some time, but let me tell you, just reading the executive summary is not important, is not enough. You have to be absolutely thorough with the executive summary, and you have to read the rest of the guideline too. How to utilize the rest of the guideline, I'll be telling you. So we are doing the venous thromboembolism GTG in some time, right? I'll show you the GTG and I'll show you how I've summarized it from exam point of view, and maybe then it will be a little more clear for you. But executive summary, not enough. Executive summary have to be very thorough. Rest of the guideline, you have to pick out important things from it. Okay. Some things you can totally ignore. For example, there are lots of studies that they would be talking about. Okay. Before reaching a recommendation, they will be talking about tons of studies that they would have done. You can very well ignore those studies, and you need to be knowing what is the recommendation and how important it is. Okay. You don't need to remember which study was done when and what was the outcome of it. But yes, you do need to read the entire thing, because there are certain things which you cannot miss and which is not covered in the executive guideline. Okay, Humera, I hope I answered your question, dear. Okay. All right. Right. So in terms of algorithms for extended match questions, I've already told this a couple of times. Extremely important to be thorough with each and every next step. This is the first thing that you're doing. This is the second thing. This is the third thing. You need to know that, if there's a pregnant lady who's come in contact with chicken pox, how many hours has it been? If it's been more than 48 hours, what do you do? If it's been less than 48 hours, what do you do? Where do you refer this patient? When do you check for antibodies? When do you give immunoglobulins, right? So this is how you're supposed to remember. Sure, we'll be helping you in the course to make the algorithms much easier. But for everybody who's not in the course, for everybody who's out there, just remember that the entire thing should be like a story, one after the other. We are doing this after this, this after this. It has to come very, very crisp sort of a manner.
Okay.
Does somebody have a question? Nasreen, your mic is unmute. Do you have a question here? Okay, I guess. Yeah. All right. Just give me a second, guys. Just give me a second. Okay, so I'm sorry, I just had to run for a couple of minutes. All right. So now I've already told you incidences and percentages. Well, a couple of years back, incidences and percentages were very important. A couple of years back, people were just focusing on recalls. People were just going and reading recalls. Even now, I believe there are people who tell you that, just do 10 years recall, then you're set and you will clear Part 2 MRCOG. I strongly disagree. I strongly, condemn just doing recalls, because one, you do not have concepts when you just do recalls. It takes you nowhere, because you just don't have Part 2, you have Part 3 MRCOG as well. And having concepts clear is essential for both the parts, right? And second, most important thing when it comes to recalls is that these questions are formulated by students who just came out of the exam. Imagine you've come out of an exam and you're trying to recall the question. How much can you even retain? You might be able to retain 20, 30, 40, 50% of it, but there's no chance that you'll be able to remember the exact question. What I'm trying to say is that a lot of times these recall questions are poorly formed, and as a result, the keys are poorly formed as well. So instead of helping you understand the concept, it sort of deviates you away from your goal, right? So what I would say, or what I would recommend in terms of recalls or in terms of past questions, is that just utilize them to maybe understand what topics have come in the past, but please just do not blindly keep reading old questions or keep reading past questions. It's not going to take you anywhere. Okay, that was my 2 cents about recalls, and that was my personal opinion about it as well, right? I've told you how to read the NICE guidelines. I told you how to read the TOG article. There's a new guideline regarding the cervical screening, that is the NHS cervical screening. The NHS cervical screening program, which was published in 2020. Now we have a summary on our portal as well. And how to do that would again be taught to you during your sessions as well. Right. So now you have 18 modules that are very important for you. For certain of these modules, there are very clear guidelines. For certain of them, there is not so much. Like clinical skills, teaching, appraisal, and assessment, there's a TOG article. For IT, clinical governance, and research, again, there are a couple of TOG articles that you need to download. Very important source for studying these topics, for studying the clinical governance, research, IT, ethics, legal issues, etc., would be your strategy. Okay. So strategy is not freely available on any medium as such. If you want to read strategy, if you want to go through it, it is advisable, it is wise to take a subscription from the RCOG website, wherein you would be able to read all this, and also you would be able to solve a lot of questions, which are very good quality questions. And a lot of times these questions come directly in your exam. Okay, it's a very good source for studying also. It's an amazing source for solving your questions. So it's my personal recommendation that if you can, please take subscription for strategy, especially for topics like this, which are not given anywhere else in your guidelines. Okay. Core surgical skills, there are specific guidelines for it. Postoperative care, there are specific guidelines. You need to do consent advices here. Okay, even surgical procedures for that matter. For antenatal care, maternal medicine, there are lots of green top guidelines. There's a nice article for antenatal care. Okay. Everything is available for you on your RCOG website. You just need to go in there, type, and you will get the PDF for these guidelines. For management of labor delivery, there's a nice article, the NICE Intrapartum guideline. For postpartum problems, again, it's a little bit scattered. There's TOG articles for mental health. There's NICE guideline for postpartum care. Okay, there's sepsis, and there's postpartum complications like postpartum hemorrhage, etc. Gynecological problems, again, has very specific guidelines. It is good TOG articles. For subfertility, again, there's a NICE guideline. Okay. Sexual and reproductive health is to be done from the BASH guideline and the FSRH guideline. Okay. For this particular topic, especially for like contraception, for vaginal discharge, for all of these topics, it is wise to just go ahead and do the recommendations from these guidelines. Okay. Early pregnancy care, I think, is my personal favorite because it's really small, really interesting, and it's very easy to cover. You learn a lot of things. There's ectopic pregnancy, there's molar pregnancy, the new guideline which has come in 2020 September. There is miscarriage, and it's quite easy and it's nice. Gynecological oncology, well, again, you as an ST5 do not need to know how to manage specific gynac specific gynac cancers, but yes, you need to be very thorough with the FIGO guidelines. Okay, you need to know how to be able to stage a particular condition, you need to know how to manage that particular condition. Okay. There are certain buzzwords that you need to be able to pick up in terms of pre-malignant conditions, like pre-malignant condition of the ovary, pre-malignant condition of the cervix, vulva, etc. And you should be able to, manage them in terms of when to refer them, what pathway to refer them on, and things like that. Okay. Urogynecology and pelvic floor problems, again, it's a quite complex topic, and usually Dr. Hassan takes it, and he's a pro at it, and he will make sure that your concepts are very, very clear. Again, there's the NICE guideline on SUI, there's NICE guideline, lots of talk articles for urogynecology as well. Okay, I briefly touched upon the modules, and I briefly touched upon where you would be able to get the guidelines from. All right. Okay. Now this is a question that everyone has in terms of what books to solve and how to solve these books, isn't it? Do we have people here who've already solved books, or who find that, solving books are easier? Anybody who has a question about how to solve books? Okay, no questions as such. I would really love it if, this session was more interactive, because I was hoping that you would come with a lot of doubts and a lot of questions to the session. Okay, we have somebody. It's easier to solve in group. Yes, absolutely, Maliha. And that is why I really love the family that forms, while solving. Are these? Yes, Dr. Anam, all the books are available for you on the portal. If you're having any difficulty, you can get in touch with the backend team. Asma is here. You can get in touch with her, and she'll be able to, guide you on where you can find these books. But everything is there on your portal. Yeah. So, right. So I was saying about solving books. Sitting and solving a book alone can become quite boring. And then there are times when you solve a question and then you figure that, oh, I didn't get this question right. So you pick up that guideline and you start reading that guideline. And it's 2 days that you just read one guideline and solved one question. So it's very easy to get lost while solving these books, especially when you're solving them alone. Well, Aisha, I'll be telling you in a bit. Right. So I was saying, yeah, it's very easy to get lost when you're just picking up a book and solving on your own. What helps is solving these books together. Like on the guide group, we have an activity wherein we have our moderators who post questions and students usually answer. And it's quite a rapid fire sort of a situation where the mentor is asking questions and the students are answering, and there's a lot of quick discussion that happens. One, it is good because it is quite crisp. Two, it is much easier to remember these discussions. Okay, instead of getting, oh, I don't know this answer, and then going and reading that guideline and realizing, oh, where am I stuck? And then you end up reading the entire thing and you forget why you even picked up that guideline in the first place, right? So it's very nice to be able to solve it in a group. If not, you can make a pair of 2 to 3. I used to do that with my friends who I found on the MedExam portal as well. And we used to sit and solve questions. We used to give half an hour, 1 hour every day, wherein we would just solve questions. So, Aisha, yes, I will do that, dear. Right. So it's important that as you are reading guidelines on one side, you should keep reading solving books on the other side. Okay. So these are books for SBAs, Tahir Mahmood, Succeeding, Rekha, Justin Conhay. These are all some really good books that are there. Andrew Sizer is a very good book, Jinesh Gupta. So these are all really good books in terms of what you should start with. I would say start with something that's new. For example, Justin Conhay is quite a new book, and That's why the keys are updated. I wouldn't say the keys in older books are wrong. They're not updated because they have given answers according to the older guidelines. Now, whenever you are solving these books, one important thing you need to keep in mind is do not take the answer for whatever it is. So if you had an answer in mind and the book gave you something else, do not believe that, oh, whatever the book is telling me is right, right? You got that question for your preparation. You realize that the answer did not match according to what you had chosen. Go back to the original article, okay? Go back to your notes, go back to the GTG, go back to the NICE guideline, go back to your session recordings and confirm what the right answer was. Okay, do not take the book as a standard for your right answers. Just take the book for practice, right? So I was saying you can start with books like Jinesh Gupta, you can start with books like Justin Cohney and then go backwards. If you can drop me a message, I can make a list of the most important books to the least, or not the least, maybe the books you should be doing first because they are more recent and they are easier, to the books you should be doing later on because they are a little more difficult, and the keys might be a little older, so you do not get confused. You can either leave that message with me or you can leave that message with Asma and she will be able to guide you. Yeah, so Malia is saying, my practice, I do look back and revise the charts and discuss questions, make a habit like 20 questions to be done every night. That is absolutely brilliant, Maliha. So it makes your revision so much more efficient, It makes the whole point of writing down notes absolutely valid. The fact that you solved questions, you went back to your notes and you revised, now that because you've been through it 2-3 times, now you will never forget what you wrote in your notes. And yes, you will not remember a wrong key to be your right answer. Okay, out of laziness you might just believe, okay, so this book has given this answer to be right, but it can cost you your marks in your exam. And it is not uncommon that people lose because of 1 to 2 percentages. I am sure you've heard lots of your friends tell you that they lost just because of 1 or 2 percentages, because a lot of people fall in that category. Okay, so I do not want any of my students or anybody who's associated with us or anybody who's there on the guide group or anywhere, even on the free groups, to fall in that bracket of just not clearing because of 1 or 2 percentages. So whenever you're solving each question, given your 100%, and go back, go refer the guideline, refer your notes, and make sure that you are very thorough with that topic and it is an unambiguous answer to that particular question. Okay, Aisha, yes, dear, do remind me on the guide group or get in touch with Asma, or I will make the list and I will share it on the guide group. Okay, perfect. All right, so Mariam says that if we do one guideline daily, we won't be able to find questions regarding that topic in the SBA. Then how are we supposed to do questions? Exactly. Well, Mariam, exactly what my point is. Please do not be like, oh, today I studied GDM, so I'm going to solve all the GDM topics everywhere in the books. How are you going to do that? You pick up a book and you start scanning for GDM questions. You have wasted 45 minutes, 1 hour of your precious time just scanning through the books and just searching for questions, and your end result was nothing. Meanwhile, you could have used that 1 hour solving questions not related to the topic. Okay, it's a good idea to read one topic and solve questions from a completely different topic. Why? Because that will keep you in touch with other topics that you're reading as well. That will open up your mind, and when you do read that question later, or whenever you do read that guideline later, you realize, oh, this question was asked that time, I didn't know the answer, and yes, this is the important part from that particular guideline. Okay, that is how you're supposed to solve questions. You're not supposed to keep on scanning for that topic in books, because that is exhausting. You will end up wasting a lot of time. I would suggest please don't do that. Okay, just go cover to cover. Take one book, go cover to cover. Do that in the groups, do that with your friends. Okay, yeah, that is how you're supposed to solve these questions. Okay, question books. So her yes, dear, I'm just getting to the EMQ parts as well. Okay, Mariam, that's great. All right, so these were books for SPS. There are some really good books for EMQs. I personally really like Peace and Harm, both for Gynac and for OBS. Good quality questions, lots of keys are old, but the quality of questions is really good. Get through is really good. Okay, Kalaivani is a great source of questions, but please be very careful about the key when you're solving these books, because like I said, they're not wrong keys, but yes, they are outdated keys. So you have to be quite careful when you're doing that. Okay, so these are the books that we need to be very thorough with. Other than that, I already told you, please, this is the link for RCOG e-learning or strategy. Okay, so please, if you can, go and subscribe for it. It's not a must. I personally didn't subscribe for it when I was preparing, but if you can, now that I go through it quite often, whenever I'm reading or whenever I'm preparing for my sessions, I really like the kind of material that's provided on strategy. So if you have an option, if you want to, if you have a lot of time for your exam, please subscribe, and you can definitely use the material that college is providing you. Okay. Now, let's have a look at the website that we have. All right. I will. Any questions here, ma'am? Please repeat EMQ books. Sir, I'll be making a list here of all the books that need to be done in the sequence that they need to be done. You can get in touch with the team. You can get in touch with me on Facebook or on Telegram, and I'll provide it to you. Just give me one day and I'll share it with you by tomorrow. Okay, sir? Okay, thank you, dear. All right. So where were we? Yeah. So if you would allow me, I will like to take you to our website, the MedExam Expert website that is there. Does somebody have a question? Okay, so this is what our website looks like. Okay, you need to log in to be able to see your portal. Once you log into your portal, now you have now there's nothing active right now, but this is where your session recordings are going to be available to you. Okay, you are also going to be able to find all your summaries here. You're also going to be able to you can see how your progress is, how your exams have been, and after each session after each module you have a test that you're supposed to appear, and this will show you how well you've been performing in your tests, and how your tests are going. All right. Okay. This is also where you will be able to access all your summaries as well. Okay. So this is how the website looks like. Okay. If you have any doubts regarding how to access the website, you can always get in touch with our lovely backend team and they will be able to help you navigate it. Okay. Well, I just wanted to share with you how our website looks like, because the new LMS is really great. Along with that, in our course, what we do is now we have a Facebook group and we have a Telegram group for all the students who are there with us on the course, and even for the ones who are not there, who are there, I'm sure they're all there on the guide group, on the Facebook guide group, on the Telegram guide group. How you can utilize these portals is for Facebook especially, whenever you are solving questions or whenever you're reading one particular guideline. For example, if you're reading the subfertility NICE guideline, make 5 questions on your own. Okay, just write what is the incidence of what is the incidence of subfertility, and write 4 options and put it on Facebook. Okay, I'm sure lots of people will reply on it. One, you have made the question, you will be able to remember the answer to it. 10 people will comment on it. That each time somebody comments, it would be like a revision for you. So the 5 questions that you have posted, would be, engraved in your mind. Okay. And imagine if you're 30 or if you're 70 of you all now. So if you're 70 or 100 of you all, and each one of you puts 5 questions, imagine the number of questions that are going to be there each day when you're solving. The beauty of how you can use Facebook and your Telegram. Facebook is easier for posting questions. Why? Because if you just put hashtag and write the topic name, for example, hashtag subfertility, and then write the question below it towards the end. Now, whenever you're revising, you just go on the search bar in your guide group or in your Facebook study group, just write subfertility. See, all the questions of subfertility will come one after the other, and you will be able to go through everything, right? So the whole subfertility question bank is revised, and these are the questions posted by you, okay? And these are the questions which your friends have posted who are there on the course with you, and there's been a lot of discussion. So it'll be great revision, great for revision, okay? That is how we intend to use these portals. Along with that, you can use Facebook and even Telegram for that matter for posting questions and tagging us, okay? So me and my colleague mentors, Dr. Zaib and Dr. Hassan, we're all going to be there. Whenever you tag any of us, we will come back there and we will reply to that particular tag. And again, even if there's some sort of explanation that we had to give, it will stay. It will not just help you then, it will help you later as well for your revision. Okay. So that is how we intend to help you with these portals that are available, the Facebook and the Telegram groups. Along with that, lots of material can be shared in Telegram, right? So we would be sharing your files or whatever you need, and you can stay in touch with us regarding schedule or regarding any communication that we want to do through these portals, okay, regarding any doubts or any communication that's there. Along with that, we will be making a schedule for the session. There's a session January, there's a session or there's a schedule for the January exam, which is followed. We post it every day on our Facebook group, on the guide group, on the Telegram group. So it's easy for everyone to, just read that one particular guideline in that particular day. Okay. Regarding the course, well, like I said, there would be a session for that module. You would be given free session reading time. Okay, we call that a mini schedule, wherein you will be covering all the relevant topics. Now, this one session of 4 to 5 hours would be the most high yield 4 to 5 hours for that particular module, because everything from the GTGs to the NICE guidelines to the talk articles and the questions and strategies, everything would be summarized in the session. So when you're revising that module, all you maybe need to do is go through that session and go through your notes. Now imagine how easy it is when you want to revise in such a systematic manner. Instead of, sitting and reading 20 guidelines from a module, imagine revising through your notes and listening to the session, right? So that is how we intend to use this material that we're providing. Okay. And there would be revisions, there would be topic tests following the revision for seeing how you're, how well you're coping. Okay. Well, now, very important thing that everybody asks about how to make notes. Shall we go through the VT guidelines now to understand how to make notes and how to go about it? Yeah. Okay, perfect. Okay, great. All right, so a quick 2 minutes break. Let me just have a glass of water and I'll be here with you in 2 minutes. Till that time, I hope if you have the green top guideline for BT, you can open it and keep, because I'll be showing you that as well and how to make notes through it. So if you can open your green top guidelines, and if you also can have have a glass of water, and I will see you in 2 minutes time. Hello everyone, I'm back. Thank you so much for bearing with me. I just wanted to show you all the green top guideline, the reducing the risk of venous thromboembolism during pregnancy and the puerperium. Now this is green top guideline number 37A. There's another green top guideline which is called 37B. Now that is for preventing any acute thromboembolisms. Okay. Now this is regarding reducing the risk of venous thromboembolism during pregnancy and puerperium. This was published in April 2015. I hope you all have this guideline and you've seen it before. If not, let me show it to you. I have it right here. Okay. So this is how the green top guideline looks like. Okay. This is an exhaustive 40-page long guideline. Okay. And I'm sure if you start reading it, and if you start from the first line and you finish the executive summary, I think you would be thorough and you would be done with the entire guideline. But if you start solving questions with just the executive summary, I'm not sure how much you would be able to gain from it or how many questions you would be able to solve from it. Okay. Now let's go to the end of this guideline. Okay. Now there's so many recommendations and so many studies that they're talking about what to do in what situation. Now this one table that they have given. By the time you reach the end, which it happens to be the most important part of the guideline, right? Let me take you there. Yes, right. So this is absolutely the most important part of the guideline, the algorithm, which is required for solving all the questions that are going to come from this particular guideline. Okay. This appendix is again very important. Okay. The risk assessment is again extremely important, right? And the contraindications as well. Now, how many of you all knew that you're supposed to go till the end, read up these appendix, and then start from top and keep adding points onto it? Did you all know that this is how you're supposed to read the green top guideline? Yeah. Slide is not changing. Oh, were you not able to see the green top guideline that I showed, Arunima? Are you guys not able to see the green top guideline that I showed? Oh, okay. I can't see. Oh, all right. Well, let me just go back to it. Are you able to see this? No? Okay, so are you able to see the green top guideline now? Yes. Oh, perfect. Perfect. Okay, so now it's visible. All right. So all I was saying is this entire guideline is an exhaustive, long, 40-page long guideline. And what happens to be the most important part of the guideline is given to you right here in the end, which is here. Okay, which is given to you here. And this happens to be the most important part of the guideline. I hope you're all able to see it now. So this happens to be the absolutely most, no, again, you're not able to see. All right. Okay, fine. Let it be. I hope you have the green top guideline with you. You can go to the end of the guideline and where you will be able to see the appendix, which we will be covering in some time. So let us see how to actually read the guideline and how to summarize it. Okay. So this is just to summarize. We all know that pregnancy is, let's start with the guideline. Okay, guys. So we're going to do the GTG on venous thromboembolism in pregnancy and puerperium. Okay. So we all know that pregnancy is a hypercoagulable state. People believe that it is because women bleed a lot during pregnancy. So it is to prevent women from bleeding out during delivery, right? So to prevent women from bleeding out excessively during childbirth, the blood clots more, it becomes hypercoagulable, And even though it is known that hemorrhage is the most important or the topmost cause of causing maternal mortality, maternal morbidity, but in high income countries like the United Kingdom and America, etc., or Europe, venous thromboembolism is emerging as the leading cause of maternal mortality because of increase in risk factors like obesity, smoking, having children at older age, etc. That is just a couple of risk factors. But these are the risk factors that increase the risk of thromboembolism during pregnancy and during the puerperium, right? So how do we assess about these risks and when do we exactly do it? So the documentation for risk factors for venous thromboembolism, this needs to be done thrice, okay? First time, second time, and third time. All right. The first time you will be doing it is in the early pregnancy or before somebody conceives, right? That is the first time the risk assessment would be done. The second time the risk assessment would be done is when the pregnant lady is admitted to the hospital for any problem or if there are any intercurrent problems. For example, in the first trimester, women are usually admitted for hyperemesis gravidarum, right? So that would increase the risk of the VTE because during that particular time, that lady would be immobile. So her risk of getting clots in the legs would increase, right? Also, for example, intercurrent problems could be like getting appendicitis during the antenatal care period, during the ANC period, for which she might need to be admitted to the hospital, for which she might need to be operated on, okay? So during that time, whenever the woman is readmitted or develops some new intercurrent problems, the risk assessment needs to be done again and the thromboprophylaxis given accordingly, okay? This is the second thing. The risk assessment needs to be done again, intrapartum or immediately after delivery, okay? So these are the 3 times when we are doing the assessment of risk factors. Now, let us look at the risk factors and how important they are. But before we go on to that, let us remember 2 things as a rule of thumb, that whenever a woman comes with hyperemesis gravidarum in the first trimester, or if a woman develops OHSS following infertility treatment and she conceives, she needs to be given thromboprophylaxis. In case of hyperemesis, till admission. In case of OHSS, till the end of first trimester or 12 weeks. Now, this is a rule of thumb. You do not need to score these 2 conditions. Okay. Now, this is just regarding early pregnancy thromboprophylaxis. If a woman is admitted for hyperemesis, give her the thromboprophylaxis till the time she's admitted. And regarding the OHSS, give it till the end of first trimester. Okay, these are the 2 situations wherein you do not need to give any sort of scoring. Now, before you go on to before you go on and start giving anticoagulation to a patient. So what is the anticoagulation that we normally give in pregnancy? The most common anticoagulation that we give?
Low molecular weight heparin.
Yes. Other anticoagulation that we can give?
Unfractionated heparin and
And
warfarin cannot be given in first trimester because of teratogenicity.
correct. But it is also an anticoagulant which can be given in dire need, like in the second and third trimester. Okay, so these are the anticoagulants. Before we start these anticoagulants, there are a couple of investigations that we get, right? That is the full blood count, the coagulation screen, urea electrolytes, and the liver function tests. Okay, 4 investigations we will get before we do a risk assessment scoring and give anticoagulation. Now, this forms the most important part of the guideline. Please pay very close attention. Okay. Now, in terms of the risk assessment and scoring and how to give thromboprophylaxis and when to give thromboprophylaxis, please remember, if the score is equal to or more than 4 in the antenatal period, you would consider thromboprophylaxis from the first trimester or throughout the pregnancy And if the score is 3 antenatally, okay, I'm talking about antenatally, you'd consider thromboprophylaxis from 28 weeks onwards. Now, another rule of thumb. Please remember, whenever you are giving thromboprophylaxis in the antenatal period, be it from the start of pregnancy, be it from 28 weeks of gestation, you have to give LMWH as a rule for 6 weeks postpartum. Okay. So if any lady has received thromboprophylaxis antenatally, she will invariably receive 6 weeks of postpartum thromboprophylaxis. Okay. I hope this point is clear. Now this score that
Yes.
that's great. That's great. Now, so this score that we're talking about here is a score of more than or equal to 2. So it could either be 2 or it could either be 3. But this is postnatally. Okay. So if the score is either 2 or 3 postnatally, you would consider giving prophylaxis for at least 10 days. Now, we're not talking about the antenatal period. This is in the postnatal period. Okay. Once we discuss the risk factors in detail, you'll be able to understand better. But do remember at what scoring, how much thromboprophylaxis is given and for how long, right? Now let us look at the risk factors. Now we've divided the risk factors in pre-existing risk factors, okay? If at all there was a previous history of venous thromboembolism in the body. Now, this VTE doesn't necessarily have to be a deep venous thrombosis, okay? There could be a thrombosis anywhere in the body. There could be a thrombosis in the sagittal sinus. There could be a thrombosis in the, in any vein in the body. It would be considered a previous venous thromboembolism. Now, when this is not related to a major surgery, that is, it is not provoked, that is, it was not because of immobilization or because of some other additional factor, it was a unprovoked venous thromboembolism, the score would be very high and the score would be 4. Okay. For now, just remember what are the scoring that we are doing, and we'll get to how to manage these patients further in some time. Okay. So if there was an unprovoked venous thromboembolism, the score would be 4. Now, if the score is 4, how much low molecular weight heparin are we giving? In the sense, for how long are we giving the low molecular weight heparin?
From the first trimester to the 6 weeks postnatally.
Perfect, Aisha. That's absolutely perfect. So if the score is 4, we're giving it throughout pregnancy and 6 weeks postpartum. Okay. Now, if there is a previous venous thromboembolism, which was provoked by a major surgery, we give the score of 3. Somebody's mic is in mute. Okay. Now, in this situation, we give a score of 3. Now, wherever we give a score of 3 in the antenatal period, we would be giving them thromboprophylaxis from 28 weeks of gestation till 6 weeks postpartum. Okay. Now we have 2 situations here. We have a known high-risk thrombophilia and we have a known low-risk thrombophilia. So what are these high-risk and low-risk thrombophilia? I'll be telling you in a bit. But if there is a known high-risk thrombophilia, the score becomes 3. And if it is a low-risk thrombophilia, the score becomes 1. Okay. What are these? We'll be touching upon them in some time. Now, if there are any medical comorbidities in labor or in pregnancy, for example, if that lady has breast cancer or any cancer, if she has heart failure, if she has active systemic lupus erythematosus, okay? Please remember the word active. If she has inflammatory polyarthropathy, if she has inflammatory bowel disease, nephrotic syndrome, type 1 diabetes mellitus with nephropathy, okay? This is not type 2 diabetes mellitus. If it is not gestational diabetes mellitus, it is type 1 diabetes mellitus with nephropathy. If there is sickle cell disease, and if that lady is a current intravenous drug user, please pay very careful attention to words like current IV drug abuser, okay? Not past, current. Type 1 diabetes with nephropathy. There is sickle cell disease here, but there is no thalassemia here. Okay, so please make a note of these very important things. All these things have a risk factor of or have a score of 3. Now, if there is a family history of unprovoked or estrogen related VTE in the first degree relative, for example, if the lady's mother was on OC pills and had a VTE, that would be a score of 1. Okay. Now coming to age, what the guideline says is age of more than 35 is a risk factor of 1. So what about age 35? How much score would you give? How much score would you give for age 35?
No score.
Perfect, Romero. Perfect, Dr. Arunima. So when the age is 35, we wouldn't give a score at all. But as soon as it becomes 36, you would give a score of 1. Now also, regarding obesity, BMI of more than or equal to 30 is a score of 1, whereas BMI of more than or equal to 40 is a score of 2. Okay. Any number of smoker, parity of more than or equal to 3, gross varicose veins or varicose veins that are above knee, okay, with associated phlebitis or edema or skin changes, all these would get a score of 1. If there is paraplegia, that becomes a score of 1. Okay. Now, preeclampsia in current pregnancy increases the score to 1. IVF or ART, this is a transient risk factor, and this score becomes 0 during the postnatal assessment. Okay. So if somebody if somebody was 38 years old and had a BMI of 32, their score post and conceived through ART, their score during delivery would, because this score of ART in IVF would become 0 during the postnatal assessment. Okay. Now, multiple pregnancy, cesarean section in labor or an emergency cesarean section is a score of 2, whereas an elective cesarean section is a score of 1. Mid-cavity or rotational operative delivery is a score of 1, whereas outlet forceps or vacuum again has a score of 0. Okay. Prolonged labor or laboring for more than 24 hours is a score of 1. If there's blood loss of more than 1 liter, or if there's post-delivery blood loss so much so that a transfusion had to be given, that again becomes a score of 1. Preterm birth is a score of 1. Stillbirth is a score of 1, but this has to be in the current pregnancy and not the previous pregnancy. Okay. Any surgical procedure in pregnancy or puerperium, except suturing the episiotomy, for example, appendicectomy, for example, postpartum sterilization, also becomes a score of 3. Okay. These are known as transient risk factors. The score stays 3 till the time the problem is there. For example, if the patient is admitted for 4 days for appendicectomy, during those 4 days, the score is 3, and she would be receiving LMWH only for the 4 days. After that, if she doesn't have any inherent risk factors for VTE, her score would become 0. And during the antenatal and postnatal period, she will not receive any thromboprophylaxis. Okay. I hope I'm making myself clear regarding the transient risk factors. All right. Regarding hyperemesis, I've already mentioned that the score is 3 and the patient would receive thromboprophylaxis only for the amount of time that she's admitted in the hospital. Now, OHSS is a score of 4. And if a lady conceives while having OHSS, she would be given a score of 4. She would need to receive thromboprophylaxis for how much? For how much time would a patient with OHSS need to receive thromboprophylaxis? Can somebody tell me?
In the first trimester.
Perfect. But that's absolutely amazing. So in the first trimester, she would be receiving thromboprophylaxis. After that, her score would become 0 and she would not be receiving any more thromboprophylaxis, right? Any current systemic infection, any immobility or dehydration, again, can be a score of, that's great, Malia, would be a score of 1. Okay. Now, I want you guys to pay very close attention right now, because this is the most important part in terms of how much LMWH needs to be given, in terms of the dose of LMWH that needs to be given. Now, there is a situation which is known as high risk or very high risk. Okay, not high risk, very high risk. In this situation, we are giving high dose of low molecular weight heparin. This high dose is not the same as prophylactic dose. And this high dose, mind you, is not the same as therapeutic dose. Therapeutic dose, high dose, and prophylactic dose are all very different. When we come to the doses in the end, I will tell you how much is the dose according to weight. But for now, just remember very high risk patients who are previous VTE on long-term anticoagulant therapy. For example, if somebody has a mechanical heart valve and is taking warfarin and has had like a previous venous thromboembolism, that would be a patient who would be very high risk. Somebody who has antithrombin deficiency, somebody who has antiphospholipid syndrome with a previous venous thromboembolism. Okay, these are the three situations wherein we would recommend antenatal high dose low molecular weight heparin, that is throughout pregnancy and 6 weeks postpartum, or until it has been switched back to oral anticoagulant therapy, or if she was on warfarin, switched back to warfarin. Okay, now this is regarding very high risk condition. I hope very high risk part is clear. Now coming to the prophylactic dose. Okay, here we have high risk, intermediate risk, and low risk. Okay, high risk we've already seen, right? Anybody who's had a previous venous thromboembolism except a single VTE which is related to major surgery. So an unprovoked venous thromboembolism, we give this a score of 4 and we recommend them to take prophylactic LMWH. That is prophylactic LMWH throughout the antenatal period and 6 weeks postpartum. Okay, this part is clear, right? This very high risk part was new, but we've already talked about the high risk part. I hope it's clear to all of you. Is it clear to all of you? Anybody who did not understand this or anybody who has a doubt regarding it? Yes. Okay, that's perfect. That's perfect, Humaira. That's great, Deepak. Okay. Right. Now coming to intermediate risk. Now, intermediate risk, like we saw, has a score of 3. Okay. So this includes asymptomatic high-risk thrombophilia. That is, somebody who has a high-risk thrombophilia but has never had a venous thromboembolism in the past. So what are the high-risk thrombophilias? Homozygous factor V laden mutation or compound heterozygote protein C or protein S deficiency. Okay. For them, we need to give them LMWH from 28 weeks gestation and again 6 weeks postpartum. Now, low risk are people who are asymptomatic low risk thrombophilia like prothrombin gene mutation or factor V laden mutation. So they've mentioned factor V laden mutation here also, and they've mentioned factor V laden mutation here. So what would you take it as? If somebody who has factor V laden mutation has had like a previous VTE, what would you take it as? What is the difference between this factor V laden and this factor V laden? Anyone who knows? Homozygous. Yes, perfect. That is perfect, Sana. That is great, Malia. So low risk would be a heterozygous factor V laden mutation. And whenever it is homozygous factor V mutation, it would be a high risk condition. Okay. So a high risk thrombophilia is homozygous factor V and a low risk thrombophilia is prothrombin gene mutation or heterozygous factor V laden. Okay. All right. So these are the 3 doses that we need to know: prophylactic, high dose, and therapeutic dose. Right? Therapeutic dose we will touch upon in some time, but high dose is just for very high risk, and these are the prophylactic doses. Okay. Okay. Now we are here to the most important appendix from this particular guideline. Now you understand how to score. Now you understand the dose. Now you understand when to give what. Okay. Let me break this entire chart into small parts for you so you can understand it easily. Okay. Now we are looking at the okay, so this half of the chart is the antenatal part, all right? And this half of the chart is the postnatal part, okay? We'll be looking at each section one by one so as to understand how much to score, okay? And how to treat that particular situation, right? Now let's look at the antenatal assessment. If somebody has a previous VTE, except a single event related to a major surgery, what is the score that we give here? What is the score that we give?
4.
4, perfect. And whenever there's a score of 4 in the antenatal period, we give thromboprophylaxis throughout the antenatal period and 6 weeks postpartum. Okay? Start as soon as the pregnancy is diagnosed, continue throughout pregnancy and 6 weeks postpartum. Okay? Now again, coming to the antenatal assessment, if there is a hospital admission, if there's a single previous VTE related to a major surgery, if there's a high-risk thrombophilia, we remember what are the high-risk thrombophilias? Homozygous factor V laden mutation and the compound heterozygote protein C or S deficiency. What are the score that we gave for all of these conditions? Score of 3, right? So whenever there is a score of 3 in the antenatal period, we give LMWH from? Who can tell me how much LMWH do we give when there's a score of 3?
28 weeks till 6 weeks postpartum.
Perfect. So we start from 28 weeks, we give it 6 weeks postpartum. Only exception here is OHSS, for which we'll give only first trimester. And any surgical procedure, we'll give it till the time that they're admitted in the hospital. Now, all these have a score of 1, right? Obesity, 1, age more than 35, 1, parity, smoker. All these have score of 1 each, right? So if there are 4 of these, you give a score of 4 throughout the antenatal period, 6 weeks postpartum. If there's a score of 3 from 28 weeks onwards, in antenatal period, if there are only 2, you would ask them to mobilize and you will ask them to avoid dehydration, okay? This is just regarding the antenatal period, right? Now, let's look at the postnatal thromboprophylaxis. There are a few exceptions that you need to note. So any previous VTE, okay? Anyone requiring antenatal LMWH, all high-risk thrombophilias, of course, they will, as a rule, receive 6 weeks of postnatal thromboprophylaxis. But we do have an exception here. So low-risk thrombophilias had a score of 1, right? But in the postnatal period, anybody who had a low-risk thrombophilia, like heterozygous factor V laden mutation, right? Along with that, if there's a family history of a DVT, the score immediately increases and this person would receive LMWH for 6 weeks postpartum. Is this point clear? This is an exception, it is not a rule, okay? Is this point clear to all of you? Yes, clear. That's perfect. Okay. Right. So again, in the postnatal period, if the score is 2 or 3, okay. In the antenatal period, when the score was 3, we gave thromboprophylaxis from 28 weeks of gestation for 6 weeks postpartum. But if we did a reassessment at the postnatal period, and this lady either had a score of 2 or 3, and if she did not receive antenatal thromboprophylaxis, okay, this is irrespective of antenatal thromboprophylaxis. For example, this lady just had a BMI of 32, okay, so that would make her score in the antenatal period 1. Only risk factor was a BMI of 32, but she ended up having an emergency cesarean section. Now her score in the postnatal period becomes how much? It becomes 3. So now in the postnatal period, she will receive LMWH for a period of 10 days. Perfect, Maliha. Exactly. So you got the point. Exactly, 10 days. Yeah. So that is what I'm trying to say. In the postnatal period, if you do a rescoring and the score is 2 or 3, we would give LMWH for 10 days. Okay. Again, postnatal thromboprophylaxis, 2 or more risk factors, that is score of 2 or 3, at least 10 days. And if there are 2 or less than that, we would advise them early mobilization and avoidance of dehydration. Now, we already discussed the agents. There's LMWH, there is unfractionated heparin, and there is warfarin. Now, the agent of choice in the antenatal period is the LMWH. The first one is that because the dose is based on weight, okay? We do not require to monitor it with INR or anti-10A levels. And it has lesser complications or lesser side effects like thrombocytopenia or heparin-induced thrombocytopenia and osteoporosis, etc. Now, if a woman has any sort of renal impairment, the dose needs to be reduced or the dose needs to be altered. Okay. LMWH is also safe in the antenatal period. It is safe during breastfeeding, unlike warfarin, which is not safe during the antenatal period, but it might be safe to be given during the postnatal period. Now, there is no need to monitor either the platelets, the INR, or the anti-10A levels. Only important to monitor platelets if the woman has had exposure to unfractionated heparin. Okay. Now, let us look at why we choose unfractionated heparin, why this is better. So this is used in the peripartum period. Why? Because the control time or the acting time, the half-life of unfractionated heparin is lesser. So we can give more frequent doses and the control is much better. Okay. That is why unfractionated heparin is given in the peripartum period. Whenever we want to switch, whenever we want to switch from warfarin to heparin, or we want to switch from LMWH, or we want to stop or change anything, we usually use unfractionated heparin because it can be controlled easily. Okay. So whenever unfractionated heparin is used after cesarean section, the platelet counts should be monitored every 2 to 3 days from 4 to 14 days or until heparin is stopped. So I already said that the half-life is shorter and it can be reversed by protamine sulfate. Now, warfarin is a very good drug in terms of control. Okay, so it is a great thromboprophylactic drug, right? Especially in women who are very high risk. For example, women who have metallic heart valve and who need a good control or who need good thromboprophylaxis. Those are the conditions wherein we use warfarin. This warfarin cannot be given in the first trimester because of risk of warfarin embryopathy syndrome. Okay, so this warfarin needs to be switched to some other anticoagulant during the antenatal period, like the low molecular weight heparin. And if the control is fine, if it can be continued, well and good. Otherwise, it is switched back to warfarin in the second and the third trimester. Okay, and also after delivery, you can switch back to warfarin 5 to 7 days after delivery. And warfarin is quite safe in breastfeeding. Now, can somebody tell me what happens or what are the complications of giving warfarin in pregnancy? What happens? What is it known as?
Warfarin embryopathy.
Exactly. Can you tell me what happens in warfarin embryopathy?
Nasal preeclampsia,
Mm-hmm.
ventriculomegaly,
Mm-hmm.
stipple hypophysis,
Very good. Okay.
effects,
Mm-hmm.
and one more.
Yeah, 5.
Short limbs.
Yeah.
All right. So let's look at warfarin embryopathy then. So there's a 5% risk of having warfarin embryopathy if it is given between 6 to 12 weeks of gestation. Okay. So 5 is an important number when you talk about warfarin embryopathy. All right. So there's a 5% risk when given between 6 to 12 weeks. LMWH is converted back to warfarin 5 to 7 days postpartum. So again, an important number. Okay. What happens if you give warfarin is there's hypoplasia of nasal bridge, there's congenital heart defects, there's ventriculomegaly, there's agenesis of corpus callosum, and there is stippled epiphysis, And this is what the baby of or a baby who's affected by warfarin embryopathy looks like. Okay. So I have a question. Warfarin is contraindicated in which trimester exactly? First, second, and third, or all three?
First.
Does somebody else have another answer? First. Okay, everybody's saying first. Deepak says first. Mera, does somebody think that we can, there might be another option for this question? Ismat, your mic is unmute. Do you want to say something? Okay. Well, so the right answer to this question is that warfarin is actually contraindicated in all three trimesters. Okay. It's contraindicated in the first, second, and yes, Maliha, perfect. So it's contraindicated in all three trimesters, but in certain situations where the risk-benefit ratio is favoring the use of warfarin, for example, in the presence of metallic heart valve, there could be a clot, it could dislodge and affect the mother's health, or it could lead to catastrophic consequences. Those are the conditions in which we use it in the second and third trimester and not in the first trimester to decrease the risk of warfarin embryopathy. But ideally, it is contraindicated in all three trimesters. Yes, but it is safe in breastfeeding. Perfect, Maliha. Okay. I hope you understood what I was trying to tell. Okay. So now let's just look at this dose of LMWH table. I hope you're all clear. Is there any doubts up till now regarding how to give LMWH, the doses, and when to start, when to stop, antenatal, postnatal period, about what are the agents, LMWH, warfarin, heparin? Yeah. Any questions up till now? Okay, nope. That's great. All right. Okay, so this table is quite difficult to remember. Okay, I've tried lots of times, but it is a difficult table, but it has to be remembered because they can just give you, like, there's a 70-year-old lady, there's a 25-year-old lady who weighs, 70 kgs and blah, blah, blah. And she just delivered, had a cesarean section. How much LMWH would you give? Okay. So in that situation, needs repeated practice. Yes, Deepak, but I will try to make it easy. So your number of practices come down and you can utilize it to read more and more guidelines. Okay. All right. So that you do need to remember how much weight needs how much enoxaparin, how much dalteparin, and how much tinzaparin, right? So first, let's look at this one particular table on your left-hand side. Okay. What you do here in this table is just keep on adding 40 to it. Okay. So with 50 plus 40 is 90, 90 plus 40 is 130, 130 plus 40 is 170, and more than 170. So here in this particular table, you're just going on adding 40 to reconstruct this table in enoxaparin. For 50, you remember 20, okay? And then you keep adding 20 each, right? So there's 20, 40, 40, 60, 60, 80, and more than 170 we'll see towards the end. Now come to dalteparin, we would add 2,500 units, okay? So if the weight is less than 50, we give 2,500. We make it double and make it 5,000. And we add another 2,500, it becomes 7,500. We add another 2,500, it becomes 10,000 units. Okay, this is how you remember dalteparin. And in tinzaparin, remember 3,500. Okay, double it at 90 to 130, right? It becomes 7,000. And for 4,500, remember 3,500, 4,500. And double this again and it becomes 9,000. Okay, so these are just some tips so that you can remember easily, but you have to do your revisions and you have to revise, and you have to take printouts, paste it on the wall, make files, make folders, keep revising, and that is how you will be able to remember it. Okay, now regarding this more than 170 kg, this is a different thing which is not like the others. So just remember Enoxaparin would be 0.6 milligrams per kg per day. Dalteparin would be 75 micrograms per kg per day, and similarly tinzaparin. Now remember, there was a case wherein we were giving high prophylactic dose. Yeah. What were the 3 indications for giving high prophylactic dose? Can somebody tell me? Does somebody remember? We did a table wherein on top we were discussing high prophylactic dose or high dose for that matter. Nobody remembers?
Antithrombin deficiency
Correct.
and antiphospholipid antibody syndrome with previous VTE.
Perfect.
And the previous VTEs
Mm-hmm.
with valve replacement previous VTE.
Yeah, not IVL replacement was an example that I gave, but yeah, somebody who's on a long-term anticoagulation and has had a previous VTE. So these are the 3 people who would be on a high dose of low molecular weight heparin. Okay. This was the very high risk group. Exactly, Noha. Very good. Okay. So here the high prophylactic dose is nothing. You just make it double. Okay. So for 50 to 90, if you were giving 40 mg daily once, for 50 to 90, you would give 40 mg twice daily. Okay. So high prophylactic dose is nothing. For people who are not able to remember it, let me just go back and I will show it to you 1 second. I'm talking about this very high risk group here. So previous VTE on long-term oral anticoagulants, antithrombin deficiency, and antiphospholipid syndrome with previous VTE. These are the 3 conditions which require high dose low molecular weight heparin. Okay, I hope you got it now. So those are the 3 things wherein we give a high dose. Okay. Now, another thing to remember in this guideline is when do we start or when do we stop giving LMWH? Okay. If somebody is having an induction of labor or cesarean section tomorrow morning at 8 a.m., okay, and if that person is on therapeutic low molecular weight heparin, does somebody have an idea who would be on therapeutic low molecular weight heparin? Any idea who would be on therapeutic low molecular weight heparin?
very high risk.
No. Very high risk was taking high dose, right? I told you
Current
about high
VTE.
dose. Yes, exactly. Perfect. That's absolutely amazing. Who said that?
Aisha.
Aisha, perfect. That is amazing, Aisha. So somebody who's had an acute venous thromboembolism would be on therapeutic dose. Okay. We saw prophylactic dose. We saw high dose for very high risk people. But therapeutic dose is somebody who's had an acute venous thromboembolism. Okay. So if somebody's on therapeutic dose, you need to stop their LMWH 24 hours prior to induction of labor or a cesarean section. And if somebody is on prophylactic LMWH, you need to stop it 12 hours before induction of labor or cesarean section. So this would be, if this is at 8 a.m. tomorrow on 15th of August, this would be stopped at 8 a.m. on 14th, and this would be stopped at 8 p.m. on 14th. Okay. Now, regarding restarting, let this person be on therapeutic, let this person be on prophylactic dose. When you restart, you would restart 4 hours later, given that there is no risk of bleeding, and you would always start with the prophylactic dose. Okay. You would never start with the therapeutic dose again. You would always start with prophylactic dose 4 hours later, irrespective of whatever this patient was taking prior. Okay. And the treatment dose is given 8 to 12 hours later after giving the prophylactic dose. If she's on prophylactic, you can give the treatment or the prophylactic dose 8 to 12 hours later. And if she was on therapeutic dose, you can start the therapeutic dose if there's no risk of bleeding 8 to 12 hours later. Okay. Now, if somebody is to receive regional anesthesia, similarly, therapeutic LMWH needs to be stopped 12 hours prior. Prophylactic LMWH needs to be stopped 12 hours prior. Now, regional anesthesia is given, for example, at 8 a.m. The prophylactic low molecular weight heparin would be given 4 hours later. Okay, so that would make it 9, 10, 11, 12. So this patient would receive LMWH prophylactic dose at 12 p.m. Now, when do you remove the catheter? The catheter for giving epidural or the catheter, which you keep in situ, you would remove that 12 hours after giving the last prophylactic dose. Okay, so after this dose, 12 hours after this, you would remove the epidural catheter, which was put in for giving the epidural anesthesia. And after removal of the epidural catheter, again prophylactic LMWH is given 4 hours later. Okay, I hope this makes sense. This is very confusing. Lots of questions come from here, but you have to be very, very thorough with it. Okay, any doubts? Okay, perfect. I assume no doubts. All right. So let's just quickly look at the contraindications that are there for low molecular weight heparin. So any known bleeding disorders like hemophilia, von Willebrand disease, any coagulopathy, active antenatal or postnatal bleeding, women who are considered at increased risk of major hemorrhage, thrombocytopenia, acute stroke in the previous 4 days, severe renal disease, severe liver disease, and uncontrolled hypertension, that is a BP of more than 200 by 120, are all contraindications for LMWH use. Okay, so I usually do this. I summarize all the incidences for everyone in 1 or 2 slides, and I've done the same for you guys as well. I've summarized all the incidences in one place, pick them up from throughout the guideline, and this is how even when you make notes, you're supposed to do it. Put all the incidences in one place, so because it needs more frequent revision. Okay, so all the incidences from the VTE guideline are here, right? So the incidence of non-fatal pulmonary embolism and DVT in pregnancy is 1 in 1,000. All right. The risk of DVT after cesarean section is around 1 to 2%. Okay. The UK incidence of antenatal pulmonary embolism is 1.3 per 10,000 maternities. The relative risk of VTE in pregnancy is increased 4 to 6 times. Okay. The risk of recurrence in pregnancy and postpartum is increased by 2 to 11%. The risk of VTE is highest within 2 weeks of initial thrombosis. And heritable thrombophilia is found in 20 to 50% of pregnancy-related venous thromboembolism. Okay, this is the first slide. And this is the second slide. The risk of antenatal VTE. Okay, please pay attention. I'm talking about antenatal VTE. Antenatal VTE is highest in the 3rd trimester. Overall risk of maximum venous thromboembolism is highest in the immediate postpartum period. Okay. Admission to hospital is associated with an 18-fold increased risk of first venous thromboembolism and 6-fold higher in the 28 days after discharge. Now, DVT is more likely on the left side because the left iliac vein is compressed between the right iliac artery and the 5th lumbar vertebra. Okay, this leads to venous stasis, which is more on the left side. And obesity, which is on the rise now, increases the risk of VTE to 3 to 5-fold. The most common acquired thrombophilia, which you will find, is the antiphospholipid antibody syndrome. All right. Okay, so these are all the incidences which I've compiled into slides. Okay, so this was the end of the Green Top guideline on venous thromboembolism. I hope you guys found it useful. If you have any questions regarding the preparation, or if you have any questions regarding the guideline, now would be the time where you should ask it. Any questions about anything, about solving books, about how to read, about anything that I did not make clear during the session, you can very well ask now. Okay. Do we have a schedule for when we will have an online session? Humera, are you a part of the group, the course group, Humera? Yes, okay. So, dear, the pre-course activities are going on till the end of the month, and you're supposed to do those guidelines for now. But your session, your schedule for the sessions would be shared with you probably in a week, all right? So you can, adjust the rest of your schedule around it. Noha, I 100% will share it on the guide group, okay? If not, you can get in touch with Asma and she will be able to help you, dear. Okay, just to tell you guys that there's Independence Day in India, there's Independence Day in Pakistan, and we are offering a discount on the course. So if anybody is interested, you can get in touch with the backend team and they will facilitate it for you. Okay, Sunit has a question. Which book to follow for module-wise questions? So like I said, even when I was talking to you about the books, just take a book and do it cover to cover. Don't focus on doing modules from each book. Okay, there are lots of books which do just question papers, and there are lots of books that go module wise, like for example P. Sinha goes module wise, and lots of other books like Justin Conhay goes module wise. So you can follow those books, but don't try to pick up one module, do one module and leave it. I would say whenever you pick up a book, start from the cover, finish till the end of the cover. It might take you a lot of time now, but when you read it for the second time, it might take you lesser time and it might be much more easier. Okay. So whenever you're solving books, right, please remember to mark the questions that you've got wrong. Either take a screenshot or mark it and keep it so that next time when you're going through that book, only read the questions that you made mistake. Okay. Don't read the questions that you got wrong, because again, of course, you will be able to get it right the next time as well. Okay. Okay, perfect. Okay, so does anybody else have any questions for me?
Yes, ma'am,
Okay.
I have a question.
Yes,
That you are telling us about to read the topics from the strategy as well.
Yeah.
So I find it very difficult. Like it's a very, they are very long modules. So how we are going to able to go with the guidelines and these AMQ books.
Correct.
So please do tell us about that.
Right. So Aisha, are you a part of the group? Are you part of the course?
Yes, I am.
So don't worry. Then we'll be covering in the sessions. We'll be compressing everything that is important for the exam from the exam point of view, and doing it like the teaching module and things like that. For the rest of the modules, don't sit and read everything that is given in strategy. Just use it to solve questions. Okay. Regarding the teaching, clinical governance, all of that, it'll be covered in the session. So it's easy for you to revise it. But don't sit and read the entire theory which is given. Theory will only come from your green top guideline. Okay, dear?
Okay, thank you.
You're welcome. Does anybody else have any questions? Okay. Deepak, do you have a question? Okay. All right, perfect. So I think we've done with all the questions or the queries that were there for all you guys. Even if any question crops up in your mind, please feel free to reach out to me anywhere, wherever you can get in touch with me. I would be happy to help you. Okay. And keep studying. I hope whatever little tips that I could shell out from my experience, from teaching and from all of that together, I really hope that it helps, and I really, really hope that all of you come out with flying colors, and I would be really the happiest person. Okay. All right. So on that note, I think all the best for you guys, for all of you guys. And if there's any doubt, get in touch with the me or backend team, and we'll be able to guide you more. Okay.
I have a
Ma'am.
question.
Oh, okay. Aisha?
I have a question.
Yeah, Isma, tell me.
Yeah, as you told that we are going to have sessions in a week or so. So what is the idea behind pre-course schedule?
Oh, no,
Because-
no. I said I will be sharing we'll be sharing the timetable or the schedule in a week, but the sessions might start a little later on. As
Okay.
yeah. So sessions wouldn't be starting this soon because we are a little held up with the September batch because they're going for exams just now. But we are there, and I hope the pre-course activities are helping you in terms of how to read the guideline. And what I would suggest is, if you have time now, take one guideline. Please read it thoroughly, like I told you to. Go through the
Okay.
entire thing, make important notes, write it with your own pen and paper. Okay.
Okay.
And whenever you're solving questions, keep adding things onto it. Don't be like, okay, there's nothing happening right now. Please utilize this time very well, because once sessions start, right, you have one week for each module. So it becomes very hectic then, right?
Okay. Thank you.
Even if you can accommodate one or two couple of extra guidelines, do it now, because it'll be easy later, because later it'll become very hectic. Yeah. Okay. Does anybody else have any doubts, or should we call it a day? All right, perfect. So thank you so much, guys.